Hi, this is Andrea Kane, and I'm here to talk to you about HIT 340 Comparative Records. We are on week 9 of our course, and we are talking about chapter 10 in our book, which is on long-term care. If you are looking at course objectives, we are on 8.5 in your syllabus, which equates to unit objectives 9.5.1 through 9.5.15. So we have lots of unit objectives on this particular chapter. If we look at what the book's objectives are, these are on the next two slides. We're going to talk about the type of care that's associated with long-term care facilities. We're going to talk about ICF settings as well as SNF settings. And we'll talk about how that is governed by very strict state and federal regulations and how that impacts what happens in terms of information management and documentation content. We will look at state and federal surveys and how those are done to long-term care facilities, and again, how that impacts the HIM field, and as well as documentation. And then we'll talk about the types of reimbursement and payer relationships, because a lot of these patients are Medicaid and Medicare, or Medicare only, but most of them you will find are Medicaid plus Medicare. Some do have some private insurance. We'll talk about the MDS, the minimum data set, and how it's used in the survey process as well as in payment. And then we'll talk about what are the priorities for HIM in a long-term care setting. What are you doing there? And what is being managed or facilitated? I have actually worked in long-term care settings for HIM. One of my roles was responsibility for the individuals who performed HIM functions at skilled nursing facilities, as well as a retirement community that had everything from cottages to independent living to skilled nursing. They had all of that there, and so we took care of all of the medical records and the documentation, and working with the providers and working with the caregivers and all of that. So I come to you talking about having experience in this area. There are really two types of facilities or nursing that we're going to talk about in the long-term care setting. One is just plain nursing facility or nursing unit, and that is for intermediate care. So notice ICF, intermediate care. The other type is skilled nursing, and that is SNF or SNF, a skilled nursing facility or unit. You can have these units in a hospital setting. For instance, I worked in one organization where they had a SNF unit in the inpatient hospital, and they called it step down. And what they would do is patients who needed a week to 2-week nursing home stay could be transferred to that step down unit and receive those services without having to leave the hospital grounds or environment or building. They could still be cared for, and then they would be released. So it worked out really well. And I guess I anticipated that. I'm coming to this slide. So yes, they can be a part of an acute care hospital, but an SNF unit is run and managed and under separate regulations, even if it is located within a hospital. So let's talk about reimbursement. An ICF, that nursing facility, can receive reimbursement under the Medicaid program. But a skilled nursing facility, or a SNF, is qualified for reimbursement under Medicare. It's that level of care. Again, think about it. An intermediate care facility is not providing as intense of services as a skilled nursing facility. And so Medicaid will pay for an intermediate care facility, but they may not pay for a skilled nursing facility. And Medicare may pay for a skilled nursing facility, but not an intermediate care facility. And it can change. So just remember, in this setting, long-term care setting, you're going to be dealing with Medicaid and Medicare, sometimes both, and sometimes one will choose one setting over the other in terms of what they will cover and pay. So let's talk about the types of patients or residents that are in long-term care. You have permanent residents that receive non-skilled care. You have permanent residents who receive special care, and you have permanent residents who receive that skilled care. You have short-term patients that are there for just a few weeks, up to 100 days. Then you have respite care that is short-term again, and it's just there for relief to primary caregivers. So let's say someone is caring for an elderly family member in their home. There may be a need to put that elderly family member into a nursing home, whether that be ICF level of care or SNF level of care, for a few days to give the caregivers respite. So that's another example of the type of residency you would see. What are some caregivers that you will see in long-term care? You will see physicians. You will see advanced practice clinicians, which you may have heard of as being called mid-levels or extenders. They're nurse practitioners and PAs, that type of thing. And then you'll have registered nurses, licensed practical nurses or LPNs, and then you'll definitely have aides, nursing assistants, and a certified medication technician, and social services, as well as activities and therapeutic recreation. And you will often have rehab services as well. And that kind of leads into the next screen. These are independent contractors. Typically, they contract to have someone on staff that provides lab and radiology. Occasionally, not all do that. Many don't. Many prefer to send the patients out to an ambulatory center or to a hospital for lab and rad. Or they may take, for instance, with lab, they may go ahead and do the blood draws or gain the specimens and then send them out for services. Rehab, that includes your physical therapy, occupational therapy, and speech-language pathology. And those can be contracted, or for instance, in one of the organizations I worked at, I was director of medical records, and one of my responsibilities was all of our long-term care facilities. And also we had a retirement community that had cottages, had independent living, apartments, and then they also had skilled nursing facility units. They had a memory unit as well as a regular skilled unit. And so we were responsible for all of their records. And because they were owned by the hospital departments of lab took care of all the lab work, and the rehab department came and actually provided the services at the owned long-term care facilities. Respiratory therapists, again, that may be an independent contractor, or if the facility is owned by a hospital, it may be somebody from the hospital coming to do the respiratory therapy treatments. Same thing with dietitians and pharmacists. So it really depends on the facility itself and its ownership and how it's set up. If it's an independent facility, odds are they'll have independent contractors for these services. If they're owned by a health system, they may be part of a hospital type setting where they share services. It just really depends. So regulatory issues, what are some of those that come up with long-term care? A standard survey is that the outcome could be substantial compliance or substandard quality of care. And of course, you don't want to be in that second category because that's not a good thing. So you want to be in substantial compliance. And through my years at that organization that I was talking about that had two separate long-term care facilities in addition to the retirement community, we had annual state surveys. And so the surveyors would come from the state and they would spend 2-3 days at each long-term care facility. They would interview the residents, they would interview the staff, they would look at policies and procedures, they would make sure that they were following all the state as well as federal regulations. And then they would let you know at the end of the survey, sort of as a preliminary exit conference, they would talk about the things that were in substantial compliance. And thankfully, the organization that I worked at very rarely had any items that were out of compliance. They worked really, really hard to make sure they were in substantial compliance. And we even had a couple of times over the years, several times over the years, where they didn't have any items that were out of compliance. So that was really cool when they had a perfect survey. Really great to see. So anyway, there are federal enforcement regulations. Those can include civil, monetary penalties, and that can be also assessed at the time of survey. So if you are substantially out of compliance and you have substandard quality of care, then you are really at risk for monetary penalties and for the state and or the Fed stepping in. And they can close long-term care facilities if they see that there are major issues and they're not being addressed. Which is a good thing because you want to protect the residents. You want them to be in a safe, high-quality, caring environment. And if they're not, you want it rectified immediately. State licensure is required for long-term care facilities. And there are rules about that, and they do vary from state to state. So you kind of need to know if you're looking at long-term care in Iowa, it's going to be different than, say, North Carolina or Indiana or another state. Joint Commission, they do have, I mean, there are several regulatory bodies that look at long-term care, and so it just really depends on which accrediting body you choose to go with. But the state always reviews, and sometimes you get additional reviews as well, especially if there's a complaint. Then the state will come in and do an investigation. And if during the investigation they find substantial non-compliance or substandard quality of care, they can initiate a survey right at that time. So while they're there investigating the complaint, they can they can say, this is so serious, or we're finding multiple issues here, even if it's with documentation, and they can immediately say, okay, we are going into full survey mode and we will survey this facility, not just follow up on the complaint. And by the way, that's the same in a hospital setting as well. If the state gets a complaint and they come in and investigate it, if they find substantial non-compliance or substandard quality of care, they can turn that investigation right into a survey, gain additional surveyors, and come in and spend many days with you. And that is not something you want to have happen. So anyway, the federal requirements. They have what's called a quality indicator survey and quality of care indicators. The survey is looking at positive and negative outcomes and validating those. It's an annual survey, and it does include complaint investigations. The quality of care indicators, those are focused more on detailed quality investigations during stage 2 of the survey. And if you're interested in more information on this, check your textbook, but also go out and Google it and you can find more information. So then you get into the resident assessment instrument and that process. So again, you need to know RAI and what it stands for and what it includes. When someone comes into a nursing home, they need this comprehensive assessment. And that process includes the MDS, the CAA, and utilization guidelines. So all of those are part of that RAI process. Because when you have a new resident coming in, you've got to get up to speed on what's going on with them, and all of this information is used. The MDS is updated on a regular basis, and it has to be submitted electronically on a regular basis. But it's really important when the patient or when the resident first comes to get these things done, because you've got to develop care plans. You've got to make sure that they are going to be getting what they need. They as an individual are addressed, assessed, and cared for. So the care area assessment process, this is looking at care area triggers and CAA resources and a summary. So the triggers, first of all, they identify who is already at risk for developing a specific functional problem or who is at risk for developing a specific functional problem. For instance, they are looking at residents who are a fall risk, residents who are at the risk of hurting themselves or others, those residents who may be at nutritional risk, residents who may have a wound that may impact their ability to be mobile. So you're identifying those who come in with these conditions or have these problems or who are at risk of developing these issues. And those are going to require further assessment. So you want to go through and make sure that your new residents are not hitting any triggers. And if they are, then you want to go through and do a further assessment and set up how that's going to be addressed. And then your CAA resources, there are lists of resources that will help you assessing that triggered care area. And then there's the summary. This is a document that you have to keep in the record. So you do this, you do all this, you identify those area triggers, you assess them, you make sure you have all the resources that you're going to need to care for the patient or to develop that plan of care. And then you want to make sure that this is all in a summary document in the resident's record. And this tells you about the fact that there's 20 conditions that can be triggered from MDS data, and utilization guidelines then assist in evaluating the problem. How bad is it? How significant or severe is it? How frequently are you going to need to continue to go back and assess and reassess and intervene and update the care plan, those types of things. So that CAA summary is going to list all the care areas that were triggered, where further documentation can be found in the resident's record as to the fact that, okay, these are the areas that are triggered, and here's what we're doing about it, and here's where we're monitoring their progress to make sure that they're not getting worse, and if possible, they are getting better. So some other documentation you'll see in long-term care records are the care plan. I talked about that. Plan of care. You've got to have a plan of care, and it has to be personalized to the patient based on their needs and these triggers. Discharge transfer documents. If a patient is being discharged from a nursing home, let's say back to home, maybe they came in after hip replacement and they were there for 2 to 3 weeks for rehab and now they're heading back home. You need to have the discharge paperwork for that. Let's use another example and say a patient's been in a nursing home for 4 years, but their family is suddenly not happy with the care, or the family wants the person moved closer to other family members, and they're going to do a nursing home transfer. That information has to be in there. And then resident rights. Residents have rights, just like there's a bill of patient rights that patients have to be aware of in the hospital setting. There are resident rights that the residents have to be aware of, they and their families have to be aware of in long-term care settings. And then when state and federal documentation requirements conflict, you always follow the more stringent requirement. And this is true not just in long-term care facilities, but in all facilities. Whenever you have one thing from the state and one thing from the feds, you follow whichever is more stringent, whichever is the more tough, the more detailed, the more demanding requirements. Some other issues you may run into that impact documentation are state licensure requirements. Depending on the state that you're in, their licensure requirements may be a little bit different. And you have to know what your state requires for licensure, and that has to be reflected in your documentation. That's why the state surveys, they come in. So for instance, you would never have an Illinois survey of an Iowa facility. because the Iowa facility has to be licensed in Iowa, and only the state of Iowa can come in and survey them. Joint Commission long-term care accreditations are similar to federal standards, but that's true of everything Joint Commission does. They work on behalf of the feds, and they want to make sure federal standards are met. So whether you're talking a hospital setting or a long-term care setting, if you use Joint Commission accreditation, they're going to have the similarity to the Fed standards. And then Joint Commission also offers disease-specific certification programs. So reimbursement sources for long-term care. You have Medicaid, you have Medicare Part A, Medicare Part B, managed care, commercial insurance, and private pay. So you need to have all of these sort of memorized, hint, 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 for reimbursement sources. And think back to what we're learning about these reimbursement sources in HIT 292, where it's reimbursement systems. So keep in mind that kind of link. So examples of reimbursement systems: Medicaid is typically per diem based on costs. Medicare is a prospective payment system. They are case mix adjusted by what's called RUGs, Resource Utilization Groups, based on that MDS data. It can also be Medicaid per diem based on level of care. So notice that Medicaid is always per diem. Medicaid is per diem. It can be based on cost, based on level of care, and they utilize the RUGs to determine that. Medicare, on the other hand, has a prospective payment system. They are per diem as well for each admission, but those also are case mix adjusted by RUGs based on the MDS data. Coding, yes, there is long-term care coding. Have been there, done that. And we had coders that coded for long-term care. You use ICD-10-CM for those diagnosis codes. So remember that ICD-10-CM is all diagnosis. You will use CPT for anything that is procedural or facility or physician related. And generally the physicians bill their own services. Again, I had the privilege of working for a healthcare system that owned those facilities, and their employed physicians did the services, provided the services, and we did the billing, the coding billing for a lot of that. But long-term care facilities often bill for contracted services, so they may have consolidated billing. It just really depends on your organization. But remember, it'll always be ICD-10-CM for diagnosis and CPT for everything else, because you're not in an inpatient setting. You're in a subacute setting. So, information management, talking about data and information flow. There is obviously data flow within the facility, and that really centers around the MDS data, the level of care evaluation, and utilization of supplies and services. MDS data you're looking at, is the patient declining, improving, or staying the same? And that all has to be documented and observed and all that sort of thing. And then you also have a lot of external data reporting. That MDS information is used by so many people, and it has to be input electronically and sent out electronically for external data reporting. Some skilled nursing facilities are still paper-based in this day and age, and some have moved into EHR settings. Some are sort of hybrid in that they use paper to document, but then after they've documented it, it gets scanned into an electronic document management system, so it's available electronically, but it started out as paper. So you have all three. You have places that are paper only, you have places that are EHR, and those are kind of few and far between, and then you have in the middle the hybrids. So what kinds of things can be electronic? Physician orders, medication management, treatment notes, financial information like the demographic, insurance, all that kind of stuff. The MDS is absolutely electronic these days. Care area triggers and care plans may be electronic. The integration of care plan with nursing, between nursing and nurse's aide for assignments may be electronic. Interdisciplinary progress notes. You think about the dietitian seeing the patient, you think about the physical therapist, occupational therapist, speech language pathologist, maybe even, I'm trying to think of who else. Oh, some of the other, like activities. They usually have an activities director and those types of things, and they are part of the progress notes. There are assessment templates for electronic health systems, and then of course you want to keep track of your incidents, accidents, infections, and other significant events. So MDS, data entry and transmission. Raven is the free software from CMS. If facilities don't have their own software to submit it, they have to use Raven. MDS has to be sent to CMS electronically. It can be through commercial software purchased through a vendor. The big vendors like Epic and Cerner do have long-term care modules, but if not, it has to go through Raven. Because CMS collects and receives and analyzes MDS data, and they have a very specific format that they must receive it in. MDS 3.0 took effect in 2010. The attestation has to be signed by each staff member that completes a portion of the MDS. So if you have 5 people that complete the MDS or a portion of the MDS, all 5 have to electronically attest to it. If you have 2 people that complete the MDS, each one of them would have to sign off electronically on it. For PPS, Medicare covered admission, the MDS is required to be completed on a 5-day, 14-day, 30-day, 60-day, and 90-day schedule. Okay, so again, if it is a Medicare covered long-term care admission, the MDS has got to be completed by day 5, by day 14, by day 30, day 60, and day 90. So make sure that you are really aware of that time frame and the fact that it is for Medicare only, that they use these specific dates. So hint, 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 make sure you know that. All right. There are examples of quality indicators based on MDS data that you can take a look at. There's the Nursing Home Compare website that you can look at for health inspection, staffing, quality measures. In terms of utilization management, in order for Part A, Medicare Part A, to cover SNF care, the condition of the resident has to require daily skilled care. And going back, there is a rule that you have to have at least a 3-day inpatient stay before you can be discharged to a SNF, and you have to require that level of daily skilled care in order to qualify. And you get 100 days per period of illness. But remember, this is Medicare Part A SNF. And then managed care has their own rules and requirements. And managed care will obviously vary based on which managed care company, group, policy, what have you. Risk management and legal issues, Mercy, there are lots. When it gets to skilled nursing facilities, there are so many potentials for risk and legal issues. And so that's why it's so important to have policies, procedures, ongoing education and training of staff and residents and what have you. But you have to have proper tracking and documentation, especially of incidents or potentially compensable events. Anything that could potentially become a legal issue. Some clinical issues that present risk to the facility include pressure ulcers. Yes, yes, those infamous pressure ulcers. Falls, particularly falls with injury. Fractures, medication errors, infections, and dehydration. Those are the hot button issues that you need to be aware of and make sure there's appropriate documentation and assessment, follow-up, and all that type of thing in the long-term care setting. And by improving the quality of care, you lower the level of legal risk. In fact, some malpractice insurance companies require certain quality of care measures at a certain level in order to reduce your medical malpractice payments, because there is an absolute link between quality of care and the level of legal risk. So what is the role of the health information manager in the long-term care setting? Well, some states require an RHIT or RHIA on at least a consulting basis, and that's really how I ended up getting into the nursing home setting, was that they were using a consultant, and it cost them a considerable amount of money because we essentially had 3 long-term care facilities that utilized a contract individual. And they were already paying me for the hospital side of life, and so they extended it, and it saved them money to let go of that individual independent contractor contract. And I just had to get up to speed with the regulations, the state and federal regulations, and then I went in and did quarterly audits at each of those facilities. And then over time, as we took over medical record responsibilities at each of those facilities, my own staff was taking care of those things and performing the audits, and I was overseeing that. So I was the RHIA that was required, and that provided the consulting basis, although I was employed by the hospital. And the hospital owned the long-term care, so that's how all of that worked out. And I think they actually did a cost back for, I don't know, $50 of my salary or something like that at the time. Some minor amount that the skilled nursing facility paid out of their budget back to the hospital for the use of my services, which was substantially less than the $50 or $60 or $70 an hour they were paying the consultant. And again, it's that auditing. You've got to make sure the documentation is there, that there's timeliness, accuracy, that it's a complete record, all of those types of things. And again, it's an external consultant versus a full-time employee. But if your state doesn't require an RHIT or RHIA, any person that has that experience can do that job. You would hope that they would get the experience or the certification just so that they would have that knowledge, but I'm sure people who have come up and worked in nursing homes for a long time may be able to gain that over time. Trends in summary: culture change movement, yes. Because the aging population is increasing in long-term care, they're really trying to change the culture in long-term care facilities. They're no longer a warehouse for the elderly or the unwanted elderly, and really trying to make them a more positive, rehabilitative type setting. Long-term care, and I want to emphasize this last point, long-term care is one of the most heavily regulated industries in the United States. That's a big part of what makes skilled nursing facilities in particular so expensive for residents and their families. It's so regulated. And the sad case of it all is that patients or residents have been in very bad situations where they have not been well cared for by long-term care facilities, and that's where all that regulation has come from, is to try and prevent the bad situations from being replicated or continuing on. So I hate to say it, but a few bad apples definitely spoiled the barrel, and now there are heavy, heavy regulations. And that is it for Chapter 10, Long-Term Care. I will be back soon to talk to you about Week 10, where we will talk about rehab. I hope you're having a great week. Take care.